Hello, and welcome to Talking General Practice, the podcast from GP Online. I'm Emma Bauer, the editor of GP Online. On the podcast today, I'm talking to Jacob Lant, the Chief Executive of National Voices, a coalition of more than 200 health and social care charities in England. In this conversation, we're talking about what patients want from general practice and the NHS more widely. Jacob talks about why patient satisfaction has reached an all-time low and what needs to happen to improve things. He also explains how he would like to see the GP contract change to give practices and PCNs more freedom to work in partnership with local communities to deliver the care people need, the importance of getting the basics right, in particular communication with patients, and how GPs and patients could make the case together for increased funding for general practice ahead of the next general election. He also has some really useful and practical advice on what practices can do to work effectively with their patients to ensure they are meeting their needs. This is a really fascinating conversation, so I hope you enjoy it. I'm delighted to welcome onto the podcast now Jacob Lant, who is the Chief Executive of National Voices, a coalition of more than 200 health and social care charities in England. Before joining National Voices, he spent 10 years helping to build the Health Watch network, which is made up of 150 local groups that champion the need of patients and service users across health and social care. Thank you so much for coming on the podcast, Jacob.
Thanks for having me, Emma.
So first, before we get into some of the stuff we wanted to talk about, can you just explain a bit about National Voices and what it is you do as an organisation?
Yeah, sure. So National Voices, as you said in your intro, we are a coalition of 200 or so health and social care charities. And in that coalition, we try and make a combination of charities that represent conditions, so things like Diabetes UK, British Heart Foundation, Cancer Research, some of the really big charities, some of the lesser known conditions as well, or kind of new conditions like long COVID. So we bring this kind of the clinical side, the condition side, and we then bring that alongside community groups. So that might be people affected by homelessness, it might be the Gypsy and Traveller community, different ethnic groups, and we try and bring all that together in one beautiful melting pot where we can actually understand how the people who are often getting the worst experiences and outcomes at the moment from our health service can be supported to get better outcomes effectively. So that's what we do, and when we sort of help clinicians and policymakers engage directly with people with lived experience of those conditions and from those communities to try and design some of the answers together, really. That's what we do.
We're a podcast for general practice. And one of the things I did want to talk to you about is patients' experience of general practice. I mean, we wrote a story about the British Social Attitude Survey about public satisfaction with the NHS and with general practice specifically. And it's basically plummeted to its lowest level ever recorded. From your experience of dealing with patients and patient groups, what issues do you think concern patients the most when it comes to general practice?
The British Social Attitude Survey is really helpful as a benchmark, and you can track how that sort of attitude towards different parts of the NHS and the NHS as a whole has changed over time. And I think the first thing that's worth saying is that satisfaction with the whole NHS is at its lowest level in the BSA. It's not just general practice. So it's kind of the access to the issues in general practice are in that backdrop of a general sort of dissatisfaction with the way in which the NHS is going. I think it's made up of a couple of things. Probably actually if we expand on both access and quality as two issues that we can talk about. Shall I start with access?
Yeah, go for it.
We talk about access and we read about it in the newspapers or as a politician talking about it. It's often incredibly simplistic in the way they talk about access to GPs. And they talk about the number of appointments that are happening and the number of people who are seen within 24 or 48 hours by their GP. And everything's about everyone needs to see their GP and they need to see them today. And they're not getting that, and that's why everyone's cheesed off at the NHS and general practice. It's actually much more nuanced than that. I think the question of access is more about whether people feel they have an easy route into making an appointment, that they can book an appointment around their lives and all the other busy things that are going on with competing work pressures, family, caring responsibilities, you name it. Can they actually fit their health needs around their lives? Can they get to see the right person at their practice? By that I mean, is that the right type of professional? Do they need to see the same person as they usually see? So is it offering some sort of continuity of care? And all of those issues are wrapped up in access. It's much more complicated about why patients are frustrated with the access they're getting at the moment. It's not just about, am I seen on the day that I call up my GP and can I get an appointment really quickly? It's much more complicated. So I think that's the first thing. Access is a big driver, but we need to really dig into the problems that people are experiencing. And then quality is a really interesting one because the vast majority of people, once they've got through the front door of the NHS, have a really good experience. They are overwhelmingly positive about the quality of care on offer, the compassion offered by the professional in front of them. And that's great that even with all the pressures that we've got, the quality is still really high. But there are groups out there for whom quality is not high. And actually, it is often the groups who are experiencing health inequalities for whom the quality of care as well as the access is a problem. A classic example of this is people who maybe have some sort of sensory impairment, so deaf or blind service users, or it might be someone with a learning disability. Actually, the quality, once you've got through that front door, if the GP practice is not supported by interpreters and translators and carers to help in the sort of interaction, that one-to-one appointment, then actually those people are getting a really poor quality of experience as well as a poor quality of access to it. I think we fall into a trap of sometimes saying access bad, quality good. Well, actually for some people, it is really both of them aren't working, and that's kind of exacerbating a whole range of issues they face.
Is it access that people care about the most? Because this has obviously been the main focus of everything that NHS England has done in primary care over the past couple of years, has all been about access. All of the money has gone into things to do with access. And it's also obviously what the media focuses on a lot. That's clearly not all patients care about, is it?
It's not. Access is much more about, does it fit around people's complex lives? So for some people, access, if they try and ring at 8 a.m., they get access, you get an appointment. Other people, they can't ring at 8 a.m. So they might try and access via the website or via an app. But they often find that those apps or websites don't work outside of business hours. They're closed, So it's not that there isn't an appointment available. It's that their two routes of access of trying to make that appointment aren't there. So that kind of makes them very frustrated and very they've got barriers before they even try and get the issue of whether there are enough GPs to meet the demand. It's much more complicated. You need to think about access and break it down into its constituent parts to understand which bit matters most to patients. And all the different bits matter depending on your differing needs at different times. So if I have a one-off acute episode of care, I might need a different type of access to if I've got a chronic ongoing condition that's interplaying with multiple other conditions. And it's really important I see someone who knows my medical history, all that sort of stuff. So access matters, but it's much more personalised than just, is everyone getting an appointment on the day they call up?
Yeah, I think that's part of the problem, isn't it? When people just look at broad statistics when it comes to access, it doesn't really take account of any of those things that you've just been talking about, does it?
Also, we see a narrative in the media about people, they want to see their GP face to face. Whereas actually, when you look at all the research on it, most people are incredibly satisfied with a remote appointment, whether that be phone or via Zoom or something. But actually, the thing that makes them dissatisfied is if they're not given a choice about that. So they need to be able to make the choice about which is the right type of access for them at that moment in time. And that's the most important thing. So again, it's like breaking down access. What does it really mean to people? And that's what matters.
Obviously, patients are quite unhappy with the state of general practice. Who do you think they blame? Is it GPs themselves? Because obviously that's really been the angle that the media has taken. Or do you think there's sort of a growing understanding now that this is about funding and that maybe there's just not enough money going into general practice and that's what's causing the problems?
It's a difficult one. This is never like talking about blame because it's not really, I think people appreciate the system's not working for patients or for the staff working in it at the moment. So it's difficult when you get into talking about who's to blame. But if we stick on that point, things like the British Social Attitude Survey show that there is a recognition that there isn't enough workforce and that the government isn't spending enough money on the NHS. That's the kind of public feeling. And on those sorts of issues, I think people do squarely lay the blame at the people in charge, government, top of the shop at NHS England, whoever it might be. Those big strategic challenges, they're saying, okay, that's somebody else to blame. I think there are issues, though, where you get very practical problems that people experience at their practice, where they definitely see it's their GP practice that could be doing things to improve the offer. So, for example, when I talk about people wanting to book an appointment online or via an app, if those websites or those apps are closed, actually that is a really frustrating for people who rely on digital access to make their appointments. So if they can't access out of hours because they're busy working during the day, they try and log on and make an appointment in the evening. they can't because the website's closed. They get in this sort of doom cycle going round and round, not being able to access care. They're not blaming government or NHS England for that. They're blaming the way their individual practice works. So actually, it is a shared sort of responsibility. But the answer lies not in blame. The answer lies in how can we work together to kind of work through solutions that, patients and GPs working in partnership to address those very practical barriers that people face.
One of the things that's a big concern for GPs at the moment is the current GP contract in England and its tiny funding uplift that it's got. I mean, it's 1.9%, while costs are still going up rapidly, wages, everything. The BMA has warned that the contract could lead to more practice closures. Is this something that you're worried about? And are you concerned about what this all means for patients?
A couple of points on this particular issue around the current contract. So I think there's a general public concern about the level of investment in the NHS as a whole. There is also broadly public support for the direction of travel of spending more money on prevention, earlier intervention, community support, and that would rely more of the pot going into general practice and community services. So there is going to be concern that actually this current contract is not seeing that throughput of funding to the GP who's working in the community. That's the first thing. The second thing is that if GP practices end up closing, because like lots of small organisations, it's a really difficult time to operate. I'm a chief exec of a small national charity. I understand the costs of running a business and keeping that afloat. It's a difficult time. The practical reality is if GP practices close, then it's not just as simple as, you go to the practice next door or the practice down the road, because in some parts of the country that doesn't exist. So actually, if patients then have to register with a different GP practice, if they can find one to register with, then they might have to travel further afield. And we know patients are already struggling with the cost of travel to appointments because they're facing their own pressures, the cost of living crisis. That's a real challenge. If GP practices close, how do you then manage the access for the population? So that is a real concern. The third thing I'd say on the contract is that whilst there are issues about the total amount of money going in, I think there are actually also issues in how the contract is set up and how we pay GPs for delivering particular services rather than just caring for their community and then assessing them on the outcomes that they support. The quality outcomes framework, so QOF, if we're paying for X number of diabetes checkups with a particular group in the community, is that the right way of funding the GPs, or should we be giving practices more autonomy to make decisions about what do I need to do to care for my community because I know them, and then judging them whether they get the right outcomes for their community, which would be, am I helping people to manage their diabetes better? Am I seeing fewer people developing diabetes in the first place? Those sorts of measures, and actually giving GPs a bit more freedom to do, here's your pot of money, go care for your community in the way that you think is best. It's not just about the total amount of money, it's also about freedoms, I think. I think it's really integral that GP practices are working with their communities on how that money is spent and actually designing where's our priority, where are we going to focus our efforts, and then how are we going to deliver a service that meets the community's needs. And that's born out of GPs working with different community groups, different voluntary sector organisations in their PPGs, making sure that they're making use of all of the feedback they've got to hand of how they can deliver a service that actually meets the needs of their local population. And that's the sort of stuff that's really, you can't set that at a national level. It's really difficult to say how that should work. But actually at a local level, you could do it if you had a bit more freedoms. That would be my challenge back, is that if we gave more freedoms about how the money's spent, is it comes off the back of having worked with your community to decide where you put that money.
Is that what you'd like to see primary care networks be doing? Is that what they should be doing then? They should have less kind of maybe prescriptions about what things they need to do. They just get given their money and off they go and work with their local community to develop services that meet their needs. Is that what you'd like them to evolve into?
That's certainly what my hopes for PCNs is that it would provide a vehicle to do that. You'd have your ICSs who can collect all the population health data and do all the fancy number crunching, and they can give that sort of insight to their PCNs. But then it's up to the PCNs to go out and engage their communities and say, well, why isn't this working for this group who we can see aren't accessing or presenting late with certain conditions, or they're not accessing screening services, or what it might be. Actually, the PCN can be doing that and marshalling a bit of the community engagement, working with their local VCSE partners, their local health watch, all the kind of assets that exist in the community to help them. Not once in over a decade working in this space have I ever encountered a community conversation that has made things worse. It's only ever made things better. You've got to be brave and you've got to make the time for it, but it always improves things.
You're talking about having those kind of relationships with local communities. I mean, that's going to help solve problems around things like access that we were just talking about. If you understand your local community and you're working with them and you're developing services to support particular groups, then that's surely going to help with the whole access challenge as well.
Yeah, absolutely. I mean, there was a brilliant example down in Kent. They were engaging with a local community of fishermen and trying to work out why these fishermen weren't presenting really late with all these health complications. It's precisely because when they were just needing to book appointments with their GP, either via the phone or the website, they were out at sea and they couldn't book the appointment. They were realizing that they needed to change the way they did booking systems to give access to these people who, because of their employment, they were literally blocked from accessing services. But actually, by engaging with the community, understood the reason why, were able to change the way access mechanisms worked and improve the kind of the experience and outcomes for people.
So are there any other issues relating to general practice that you think are really important to patients, from your experience of working with them?
One of the things that comes up a lot that is a patient frustration and is the length of GP appointments, one problem per appointment type attitudes. It's really interesting because obviously that's the way that practices are trying to manage the flow and trying to manage equity across all of the people who are trying to get access. At the same time, because it's so difficult to get a GP appointment and also patients know that GPs are under a lot of pressure, you end up in this where people store stuff up. And so they might think they're going with 3 or 4 things to help. You have to work with that rather than say, sorry, one problem at a time. And some GPs do that really well, others less so. It doesn't really matter. I was reading a story earlier today that was shared with me by Mind, the mental health charity. Wonderful case study of an individual who having a really tough time with their mental health, self-harming or having suicidal thoughts. And actually, they went to their GP and they were expecting to have a very negative experience because lots of their past experiences had fobbed them off, had said, no, there are too many problems here, like I can only do one thing at a time for you. And actually, the compassionate response of the GP took the time to listen to that person, probably take a little bit longer than they should have done in that consultation, probably actually saved lots of other follow-up appointments and also probably saved a potential risk of serious harm to an individual because they took the time to do that. So in this world of incredible pressure on primary care, try not to forget the compassionate care and treating the person in front of you and the range of problems they might have. I know that, I have the screaming list of everybody else trying to get through the door as well, but actually it matters so much. You could read that in that one patient story. It almost, the person says, it restored my faith in general practice because this GP took the time to understand what really mattered to me rather than just, trying to push me on and move on to the next patient. So really trying to hold on to that compassionate care and how that fits alongside like one appointment, one problem type policies. I know that everyone who trained as a GP went into the profession to make a difference and care for people. And we just need to try and hold on to that in these difficult times.
You work with a lot of charities who are condition-based charities. These are obviously people who've got long-term conditions. Obviously, continuity is really, really important for those patients, isn't it? How do you think general practice is doing on that? What can you think is important when it comes to continuity?
I think continuity is really important and it does vary from one patient to the next and depending on your need. Sometimes people need to see the same person time and time again because that's kind of builds the relationship and builds the understanding of the medical history and all that sort of stuff. But it doesn't always need to be the GP. Again, someone who goes to have their diabetes checkup with the pharmacist or with the advanced nurse practitioner or whoever it might be, they build a relationship with that person. And that's the continuity of care. So it doesn't always have to be with a GP. I think there are other people out there who just need continuity with the practice. So they don't necessarily need to see the same person each time. They just kind of want it to feel like the practice has at least an understanding. So if you see 3 different GPs about the same problem, you want them to know that you've already seen another GP in the practice and talked about that issue. So how do you address that problem? That's more sort of like informational continuity that matters for the individual. And I think kind of how we deliver those is really important. And I actually welcome GPs being assessed on how well they're targeting and providing continuity. So we shouldn't be trying to give continuity to everybody because that's not possible given where we are at the moment. And it's also what not everybody needs. But actually, Let's reward GPs on them actively seeking out who benefits most from continuity. How do I provide them with that continuity? Is it the same person each time, or is it just a better flow of records between professionals? And see if that kind of helps drive a service that people feel is offering them more wraparound care than the kind of very episodic interactional care that we offer at the moment. And I think that would go a long way to working out which practices are doing things in the right way for their patients and which ones are not. A good example on this would be the GP patient survey shows that continuity of care has fallen significantly in recent years. But I don't know from that whether those GP practices are concentrating their continuity efforts on the right patients and actually they're doing a better job than they were before. If we could surface that a little bit, that would be a positive news story for primary care and positive news for the patients who need continuity, and we'd be celebrating it. Whereas right now, the profession's being hammered for not offering continuity, which isn't the case. If we could surface that story and tell it better, that would be a good thing.
It's a really interesting one, continuity. Obviously patients like it, GPs would like it. The Labour have already said that that's something that they're looking at incentivising. The government even says that it wants it as well, although it's not really done anything about it. It seems like it's likely that we might see some kind of form of incentives around that, I would have thought, in future.
It would make sense because, as you say, it goes to the heart of a lot of the problems. We know it makes clinically an impact on people as well. So those who need the most, they benefit it from the most. It makes sense to incentivize that. But then how you deliver that continuity is also up for grabs. As I was saying earlier, give GPs the freedom to work out how they deliver continuity. Is that by always seeing the same practice nurse? Is that by us having better information flows? It doesn't really matter how you're doing it as long as the patients feel like they're getting better continuity. That's what matters.
One of the other things I wanted to talk to you about was your manifesto. So that manifesto sort of highlights the issues that National Voices is going to be campaigning on in the run-up to the general election, probably before the end of the year. A lot of those things that you've got in there are probably things that would really resonate with GPs. And, the first thing you mentioned, and you have kind of touched on this already when in this conversation, is you want to see some action on tackling healthcare inequalities. What do you want to see happen on that? What would you like the government to be talking about in that space?
Manifestos are always tricky things to kind of put together, and you have to sort of play a little bit to the headlines of this, and it's difficult to get sort of complex policy solutions across in a manifesto. The first point we talked about is actually, if you want to address health inequalities, you have to have a good target and a good measure of that across not just the health service but all of government. So we're calling on the political parties to focus on healthy life expectancy as a core target. But more than that, not just actually improving healthy life expectancy, because we know recent ONS stats show it's going in the wrong direction, but actually reducing the gap that we see in healthy life expectancy between communities, because it can vary by 10, 15 years between postcodes even. Focusing on that gap and reducing that gap will be really, really important. Now, I spoke at the Royal College of GPs manifesto launch, and there's a lot of parallels between what we're calling for and what they're calling for, because they've asked for not just more money to go into primary care, but more of that to be directed to the underdoctored areas. And that was one of the things that will directly help address that healthy life expectancy gap, is that we need to be putting more doctors and more resource into the areas where we've got the most health inequalities at the moment. And so there's a lot of common ground there between patient groups are asking for and what the GP profession is asking for in terms of how that investment works to address inequalities. That's the first thing that we've asked for. The second thing I think that we've really pulled out in our manifesto is this concept about getting back to basics and really getting the basics right. So a lot of the time politicians and the press want to talk about the shiny things, about how the AI is going to revolutionize the way that general practice works or what have you. And actually, it will change over time, but it's not the core of like, how do you fix an ATM blockage on the telephone? How do you make sure that if you've now put your digital telephony in place, the on hold message is actually useful to patients? How do you make it easier for patients who can't attend appointments to cancel their appointment and free it up for somebody else? So some of these real basic things that are frustrations for patients, actually we need to focus on getting those right. And again, it was great to see the RCGP calling for more focus and support on front of house staff and admin staff to free up GPs to focus on clinical time with patients. I know that's something very much that we're calling in that getting that basics right. It needs the workforce, it needs the admin staff, who often are not recognised or celebrated in any way, but they do a hugely important job. let's invest in those people. They can support patients to navigate our complex NHS, and it really help kind of focus on those really basic interactions of care and how you help people get around to get the support they need. So there's a lot of parallels between what we're asking for and what the RCGPs, the representative of the profession, are asking for, at least.
I was going to ask you about that managerial and admin thing, because I mean, in your manifesto, you say that you think it's a bit of a gaping hole in the NHS workforce plan.
It is.
Obviously, we write a lot about the kind of clinical staff and stuff, but once it really is a gap when you actually start thinking about it. Do you think there just needs to be more investment in those staff or better training? And what would that look like for general practice, do you think?
I think more investment, better training, more of a career path as well, of recognizing that it is it's a professional skill in its own right. It's not it's not a low skilled job. Actually understanding the complexity of the system, having the right skills and compassion to deal with frustrated people who are in pain or people who are frustrated on behalf of a loved one. It's a really difficult skill set to master. And actually, when you get a receptionist or someone who's working really, really well, they're worth their weight in gold. So I think it's just a lot of celebrating that those jobs matter. And when you get something like the long-term workforce plan that completely omits to mention them at all, or even worse, suggests that they might be replaced by an AI bot at some point in the near future, it just belittles that. And that's not where we need to be. AI and technology can definitely streamline things, but it won't implement itself. And actually, it's going to be the admin and technical staff whose job it is to implement these systems. We're not going to be asking the GPs to do it. They should be spending the time with the patients, making the most of their skills. So how do we celebrate that and make the most of the skills of the admin staff? And finally, we think that it's a gaping hole in the long-term workforce plan. Partly because it's also, you can train admin staff faster than you can train a clinical member of staff. It's still a skilled job, but actually because the risk is lower, you can train someone up and put them into the system. They can be making a difference far faster than training a new GP, which is going to take longer. And we desperately need more GPs. But actually, it's something that you can do today that would make a difference in a matter of months, not a few years' time.
We're talking very much about general practice, but you also in the manifesto, you do talk about the importance of hospitals and the way that they communicate with patients. And the reason I'm asking you about this is because this is a real driver of workload in general practice. Patients who are on the waiting list, you don't know what's going on. They often have to come in repeatedly. Sometimes it's because their condition is getting worse and they need to see someone clinically, but sometimes it's just because they don't know what's happening and they want someone to tell them about when they're likely to get treatment. What do you think hospitals need to do about communicating with patients? Is there anything they should be doing to make things better?
Yes, I mean, there's lots of work that's been done in the past about how hospitals can communicate better with people who are both on the elective waiting list, for example, if they're waiting their procedure, better communication when patients are outpatients in follow-up appointments and all that. At the moment, what happens is we see when there isn't good communications or isn't good mechanisms for it, people get bounced back into primary care and they ask their GP. And the GP doesn't know. I mean, the GP might be able to go and find out, but that's another job to add on to primary care. Again, it doesn't have to be in secondary care, it doesn't have to be in primary care. But if you have good admin functions that get these basic things like communication right, and you help primary and secondary care talk to one another, it shouldn't really matter where the patient asks, where is my referral at to, or where am I on the waiting list, or I feel like this has changed in my condition. Does that alter my status on the waiting list? It should just all happen seamlessly around the patient. But that requires that investment in those non-clinical facing roles in order to get that right. As I say, having a situation where secondary care just bounces people back into primary care because it's not very good at patient comms doesn't work for the hospital, doesn't work for primary care, and definitely doesn't work for the patient. So it's not a good system all round.
There's a lot of crossover between what you want and what GPs, like you mentioned the RCGP, but some of the things you're talking about as well are things the BMA would want as well. But from the national media, we often get this sort of sense that patients and GPs are pitted against each other. But, we talked about the fact that patients probably do support more funding for the NHS and more funding for general practice. I mean, both the BMA and the RCGP think it's really important that GPs make the case for more funding in general practice in partnership with patients ahead of the next election. I mean, what's your feeling about that approach? And do you think it would sway politicians?
I think it would sway them. I think politicians do care about what their constituents think, particularly the closer you get to an election time, and really want to be in tune with that. The challenge at the moment in the narrative, the way this plays out, is that profession talking about being busier than ever. And that's true. There are more appointments happening now, significantly more appointments than there were last year and even 5 years ago. The volume of activity's gone up. But we know the satisfaction has dropped at the same time. And I think there has to be a recognition of that is the truth. That is what has happened. So I think the message that would resonate most for politicians is for whether it be the BMA, the RCGP, whoever it is, to say, look, the fact is we're doing more activity than ever before, and yet patient satisfaction is at its lowest level ever. There's something going wrong here. We can't keep pace with the demand. Yes, we can work together to improve some things, but fundamentally, something's got to shift because we've got to change something. And often that falls into really zombie policy suggestions at the moment about like charging patients for access to GPs, for example, and that would reduce demand. That wouldn't reduce demand. I tell you right now, what all that will do is means all the people who can't afford it will end up going to A&E and it'll pop up elsewhere in the system, and it will cost more to administer the charges than we'll ever make back in the charges. So it's just a dreadful idea. So we need to be thinking about how that argument of clearly the demand is going one way, satisfaction's going in another, how that builds the case for more investment, rather than GPs and doctors saying that, we're working harder than ever, we're doing everything we can.
Bearing that in mind, and based on your own experiences of working with patients, what key bits of advice would you give to practice about how they could work more effectively with their own patient populations?
The biggest message I give is about be inquisitive about how it's engaging with your service. Understand the demographic of your community and also understand the demographic of the patients who are walking through the door. Who are you not serving? Who is developing all of the health problems that are going unseen at the moment? Because that health need is there. It's not accessing primary care. It's either storing up problems or it's going to A&E or what have you. So I think that's a really good starting point, is be aware of the people that you're not seeing, and then think about how you work with your local communities to engage those people and find out what you're missing out, and use that as I would say, look, this is the need that we can't meet at the moment. I think the second thing I would say is actually listen to patients about what they're saying about your service and really understand. Sometimes there's a tendency to be like, I can't fix that because that's beyond my immediate control. So I can't fix that the bus route no longer goes past the GP surgery, right? That's out of my remit, but it now means a whole bunch of patients can't access my surgery. But the things you could do is think about how would I make appointments available for those people at a time that they could get to the practice. If the bus is not as convenient as it once was before, how do I make appointments available for those people? Can I go and do a drop-in centre in a local community centre one day a month or something? Can I do something else that actually can help the way in which the practice works with the community and is a bit more flexible in how it delivers services? Try and engage on the thing that the patients want to talk to you about rather than the things that you think are in your immediate control.
Thank you so much for your time, Jacob. I really appreciate it.
That's all right. Happy to help.
Well, that's it for this week. Thanks for listening, and thanks so much to Jacob for taking the time to talk to me. I'll be back next week with our regular news review, so please do join me then. In the meantime, don't forget you can keep up to date with all the latest news affecting general practice and access a host of other resources on our website at GPonline.com.